Hi, this is Dr. Bob Dannenhoffer, the Public Health Officer from Douglas County, with another of our Facebook Live events. I'm wearing my balaclava tonight. I like this one a lot. It's comfortable to wear and works pretty well. But I'm going to take it down so those who read lips can see my lips. Again, this is Dr. Bob Dannenhoffer, the Public Health Officer from Douglas County. It's the June 8th tonight, and this is our manyth, probably 30th or so, update on what's happening with COVID. So it has been a bad week. The world is now at over 7.1 million cases and 400,000 deaths. To give you some perspective here, it took us about 3 months to get the first millionth case, but the last millionth case only took 10 days. So it's really exploding, and really exploding far faster than any of us thought would be in this midsummer time. And so for the rest of the world, it really is worrisome. South America seems to be the most worrisome place. So Brazil, Peru, Ecuador, also some in Central America and Mexico seem really to be exploding now. These are all really warm areas this time of the year. And so heat does not seem to be a big impediment to the disease. And the disease is growing very fast. It's also a little concerning in that the president of Brazil has told them to stop sharing the numbers. So we may not know exactly what the numbers are in Brazil, but at least the reports until now are pretty worrisome. We think that they probably had the fastest rising case rate in the world. Otherwise, in the world, we're seeing lots of cases in India, and India is very worrisome because it's a very densely packed country that has a wide range in incomes, from places in India that look almost first world to places in India that have really abject poverty. And we worry about spread in those areas because there's lots of close contact. There's not particularly good health care. And so we worry about spread in those areas. We're also still seeing a lot of cases in Iran, a lot of cases in Russia. So it's really worrisome in those areas. However, the really good news is that New Zealand, a country that really looks a lot like Oregon, I'm told, has recorded that it is now COVID-free. So there's no circulating COVID in New Zealand. So that's a very good sign. New Zealand didn't do anything really special. They did lockdowns like everybody else. They did a lot of case investigation, a lot of case finding, and were able to really cut it back in that way. In addition, the people in New Zealand really seem to work together to go ahead and find cases and bring them down. So it looks like New Zealand is a place you can go where there's no circulating COVID. Unfortunately, we're also seeing at the same time Sweden. You remember we've talked about Sweden a lot because they've tried a no lockdown approach, and they're having a lot of cases. So that when you look at the number of cases versus bordering Norway and Finland, they're having a lot of cases and a lot of deaths. So we'll see in the end if this was a good strategy, but for right now, it's not looking so great. In the U.S., we're seeing a fairly stable situation. There are places that have increasing cases and other places that have decreasing cases. But overall in the U.S., we're still at about 20,000 new cases every day. And that's a lot. And we still have a death rate of about 5 or 5.5%. So with 20,000 new cases, that means like 1,000 deaths a day from COVID. Really a lot. Oregon seems to be doing a bit better, although you'll remember about 10 days ago, I said, wow, the number of cases is way down. Really looks like it's at a nadir. We were at 20, 30, 40 cases a day. The last 10 days have really changed that. So we went down to a low in the middle of May, but we're really starting to see an uptick. And in fact, the last 5 days have been some of our worst days ever. Yesterday, the worst day ever. In Oregon. Now, some of that is due to some big outbreaks. There's a big outbreak at the Pacific Seafood Company in Newport, and some outbreaks at the penitentiary, and then an outbreak up in Hood River. But nonetheless, this is a lot of cases and shows that we are clearly not past this. Oregon still is the 4th lowest attack rate in the country, so that's good. But if we're having all these cases and still have a low attack rate, you realize that this disease is still very active in the rest of the world. Oregon is doing pretty well, though, with a low positive testing rate, only 3 or 4%, which is good. And then we get to Douglas County, we're even doing better. And I think this is like the broken record, but looks like we're doing better. We're still 29 cases, so not really a big uptick in the number of cases. only 26 of those are recovered, so only 3 active cases. Again, we've had no deaths, and we have the long-term hospitalization in Portland, and then 1 person who was hospitalized this week for different reasons. So they still could count as a hospitalization, but presumably not because of COVID. So overall, Douglas County is doing pretty darn well. So that's where we are overall. We've got some interesting stuff to go over, but let me take your questions. So someone says, they say wearing masks protects others. Doesn't it protect the wearer too? So it clearly protects others. So if you'll remember my little video with the spray can, it really tremendously decreases the amount of stuff that I make. In terms of protecting me, if I was wearing a very well-fitting, very good mask, it would protect me. So the N95 masks that healthcare workers wear definitely do work, but they're very uncomfortable to wear. They're hard to fit. Once you start moving down from a N95 mask, which is the highest kind of mask, to a surgical mask and then to a face covering, the protection for the person wearing the mask is less. And if you're not used to wearing a mask, you touch your face a lot. And so for the wearer, it's kind of a mixed bag. It may help a little bit, but it could hurt a little bit if you've not touched your face a lot. And we know, watching when people wear masks, that they do touch their face a lot. So again, wearing the mask is mostly to protect others. It may protect you a little bit. Interestingly, new stuff that's come out that actually eye protection, glasses, does seem to also be protective. So, get some cute glasses and try them out. So Dennis says, is it because counties are opening up that we're seeing a second wave? I don't know yet. It looks like most of the cases that we've seen in the last week were related to outbreaks in plants in rural areas that really don't seem to be related to the opening up. So the specific seafood group, the place up in Hood River, and certainly the Oregon State Penitentiary didn't really open up. So I don't know yet whether that's because of the opening up or because these are outbreaks that were otherwise going to happen, but we'll certainly know a lot better in the next 2 weeks. So are the increase in numbers due to pre-surgical screening or due to the reopening? So pre-surgical screening has only added 2 cases to our numbers, so and it's similar throughout the rest of the state. So it has not added that many cases, or due to the reopening, or just because it was going to happen. I'm not sure which of the 3 it is, but I don't think there's any one of the 3 answers that could account for all of it. So I think these plant cases, when you like in the seafood plant or in the meat plants back in the Midwest, they just seem to happen. And probably what happens is there's what we call a super spreader event where one person gets in there who's very contagious and brings it to lots of other people. And that's why we worry that this could happen at any time, and why probably Southern Oregon has been so lucky. We just haven't had any of those super spreader events yet, but they could happen at any time. So I'm planning seeing my great-granddaughter after 3 months of self-isolation. I'm in the high-risk group. Is this stupid for me to do? And the answer is, I never call anybody stupid. What I say is there's a risk continuum from being very safe, which would be staying home, never seeing anyone, to being what I think would be foolish, going out to the bar every night. And this is somewhere along the way. On the other hand, visiting your great-granddaughter is an incredibly important thing. And so I talked with my mom several times this weekend, and we weighed that, the risks and the benefits. And she didn't want to put anybody else in the point of giving it to her and then feeling guilty. So she's staying home. But that's her analysis. Your analysis may be different. And so your analysis may be that seeing my great-grandchild is the thing I most want to do in the world, and I want to be safe about it, so we'll do it. And then that would be not an unreasonable thing to do. I mean, I wouldn't see all 103 of your great-grandchildren, but if you want to see your great-granddaughter, I think that's okay. If you've self-isolated for 2 weeks, you're not going to give it to her. Pretty hard to get her to self-isolate. but kids don't seem to be that contagious with their grandparents. So in the whole risk of things, this is I would say a low moderate risk. And if you're ready to take that low moderate risk, go for it. Yeah. I'm wondering, with all the protesting, is COVID distancing now a waste? No. So these protests were horrifying from a public health standpoint, right? There were lots of people out there, lots of people yelling, and we think when you yell or shout, you produce a lot of droplets, a lot of people relatively close together. On the other hand, there was lots of milling about, if you watched, where people didn't stay in one place at any one time, and they were outdoors. So that counteracts this. But, all of us in public health are just frightened about seeing a big rise in cases in the areas there were lots of protests. Again, it takes a while. Let's say you got exposed last Monday. You were out of protest last Monday, one of the biggest protests, and got exposed then. You likely wouldn't have symptoms until Friday or Saturday. You likely would see what is going on. You probably wouldn't get tested till Monday or Tuesday. You wouldn't get the results till Wednesday or Thursday. So we think this is the week, if there are going to be cases, that we'll start seeing them. And so I'm holding my breath on that. So Aaron says, are we ramping up testing or on the same track as we have been? So I think we are ramping up testing. I think the number of tests in Oregon is increasing. Now, interestingly, the number of symptomatic people is way down. So the number of people with cough and colds and whatever is way down, because people are doing a pretty good job of social distancing, and it's more in the summer when there's less coughs and colds. So we're seeing less symptomatic people. We're seeing more asymptomatic people. And then we're now starting to test more groups. So, for example, Aviva is bringing in some doctors from across the country, and they're testing all of them. There are some seasonal workers that we're testing. So I think as the time went on, we're moving from more symptomatic people to more asymptomatic people. And the number of tests is great. Now, there are some people who want sort of a strict number. You should test 1% of your population every week. That's really foolish, right? You should test enough so that almost all of your tests are positive. So if 1% of your population was getting sick, obviously testing 1% of your population is not good enough. You would need to test 20 or 50% of your population. But if only 1 or 2 people a week are getting sick, you probably don't need to test that many. So there is a very good website called COVID-19projections.com that suggests how many tests each area needs to do. In Oregon, we're doing about 15,000 tests a week. Suggests we only really need to do 1,000, but New York, which is doing so many tests, needs to do 5 times as many. So really related to the background level of disease. So in kids, do they build antibodies, or are they in danger by being around other people who are sick? Hard to know. We do think that kids probably get this, usually have a mild illness, and don't spread it to lots of other people. On the other hand, since they don't get very sick from it and they don't spread, building antibodies is a little less important. So we don't know. We do think that school is going to be on in the fall. Other places that have started school have done this relatively safely. We think it's going to be on in the fall. We think kids will probably build up some antibodies. But whether those antibodies are long-lasting or protective against a repeat infection, we don't know. I think the best data now suggests that they'll probably be somewhat protective, and they'll probably last 6 months or a year, but that they won't be lifelong. Yeah, so Lori asked some questions about what will kids be able to do once school opens up. I do not know the answers to this. I'm on a couple of work groups that are working through this, and it's very complicated. So, think about school. Kids get on the bus, they take the bus to school. How are you going to do buses, right? Because buses, is all the different grades. So now all of those kids from the whole area mix on the school bus. How do you enforce distancing on a school bus? And then they get to school. Do they mill about at the beginning of school like they usually do? Do they go on the playground? When they go to class, do they now switch classes to go to art class and music class? Do they eat lunch at their desks? Do they go to the lunchroom? All of those questions I do not know the answer to, but I will tell you from an epidemiologic point of view, if you were able to track them through the day, you'd see that that would tremendously increase the number of contacts. So I do not know what's going to happen with school. I think school will be open, but I do not know what school will look like. In many of the countries that have done it, what they've done is they've done schools in small cohorts. So the kids basically get to school on their own, not taking the bus. They then are with a group of 20 or 15 or 20 other kids. They stay with those 15 or 20 other kids through the day and then go home again on their own. And so that through the whole day, they only have 15 or 20 contacts. We think in the way schools used to be, a kid could easily have 200 contacts in a day. Imagine 20 or 30 kids on the bus, maybe more than that. And then they would go and they'd mill around on the playground, maybe 20 or 30 other kids. They'd have 20 or 30 kids in the class. They'd have another 30 or 40 kids in the lunchroom. They'd go out on the playground, have another 20 or 30, go back for gym class, have another 20 or 30. And you could see for a day, they may have contact with almost everybody in the school. I don't think we'll see that, but I don't know what it's going to look like. So is there any scientific data on the virus weakening? No. So I was on a phone conference today about this. There is clearly data that this virus may change a little bit. There's one group in Arizona that thinks it changed and got stronger. There's a bunch of people who say it changed, but it didn't really change very much. And there are other people who are suggesting that it may change and get weaker. I think if you're looking at other viruses, it's not what we've seen. So think of other viruses that have mutated. And generally, they don't get weaker and go away. So if you think of HIV, HIV has certainly mutated a lot, but still just as infectious now as it was before. Influenza mutates, but usually when it mutates, what happens is the stronger variant wins out over the weaker variants. And that's why sometimes the vaccine doesn't work, because they've made it against a variant in February, and by November, December, when it circulates, it's a stronger variant. It certainly is possible that it turns into a weaker variant and then goes away, but that's usually not what we see. I was on this conference today and said, don't hope for that. I think what you have to consider is that this virus will likely stay about the same virulence. Yeah. So Janice says, I heard California's in phase 3, or their phase is different than ours. Are all states different? And yes, it's so freaking confusing. And so to give you a background on this, the CDC came out with a pretty nice thing in the end of March, which talked about reopening America and talked about phase 1, phase 2, and phase 3. That phase 1 would be the first early steps. Phase 2 would be a further reopening, and phase 3 would be back to normal. Well, when I looked at that, it was like, well, the difference between phase 2 and phase 1 and phase 2 is not very far, but the difference between phase 2 and phase 3 is many miles. So phase 1, as we did, a little opening. Phase 2, a little more opening. Phase 3 is back to normal with unlimited sized gatherings and unlimited stuff. And that won't happen really until we either get enough immunity through a vaccine, we have a very effective treatment, or we let this run through the community for years until we get enough immunity. So while there's 3 weeks between phase 1 and phase 2, there's at least going to be 3 months, maybe 3 years between 2 and 3. And so different people come up with different phases, and it is so confusing because every state need to come up with it. Now, the idea was when CDC came out with this, they would come up with guidelines for what is in phase 1, phase 2, and phase 3. And for whatever reason, thought to be political, their guidelines were withheld for many, many months. And because they were withheld for many months, states came up with their own plans, and their plans all look different. They're all different names, they're all different ideas, and it is so confusing. So in one state, water parks are open, and the next they're not. In one state, bars are open, but in another they're not. In one, hair salons are open, and the other is not. And it is really confusing, and it is confusing because each state had to come up with their own, because the federal guidance didn't come out until most states had already opened up. And now the federal guidance is so non-specific that it really is hard to judge what to do on that. So California phases are different than ours. So there are any more children coming down with the Kawasaki type disease. So I looked at that today. There are no more cases in Oregon. There are some cases in the south of the U.S. more cases in New York, and a bunch of cases in England and Italy. It appears to be pretty much the same thing, a Kawasaki-like disease, many times more common than it had been before this, so probably related to COVID. About 80% of the kids have some evidence that they had a COVID infection, likely a few weeks before, so not right at the same time. And there are still some cases. Now, again, because the number of cases in the U.S. is kind of, in New York certainly has started to come down. We're starting to see fewer cases there, but starting to have other cases pop up. It's in the hundreds now, so it's not super common, but when it happens, apparently it's quite bad. So how are casinos reporting or following the guidelines? So I've not been to the casino, but I understand that they're doing a pretty good job, actually, with maintaining it. And people ask me about what the risk of casinos was. And actually, it turns out that casinos are a lot of activities. Bingo, probably not a great activity because of the closeness of people. But the slot machines, which are the big things in casinos, probably okay because you can shut down every other one and then people are kind of distanced. In addition, you can really distance people, and as soon as they get done with the thing, you can have somebody come and wash it down. In addition, casinos tend to have excellent airflow, and because they have excellent airflow, they can mitigate the risk in that way. On the other hand, there's some things that casinos do, like crowding around a table, which they're not going to allow, or crowding around buffets, which could be problems. But I think the casinos recognize that if they see outbreaks associated with casinos, it's going to kill their business. And killing their business is what they're not looking to do. So I think those businesses are going to be really quite cautious about reentering. So Linda asks, if 90% of the people get this recover, if kids rarely get it, why are we continuing the lockdown and waiting for a vaccine? Shouldn't we open up and focus on protecting people with underlying issues? So this is a strategy, right? So there's a couple of strategies, right? There's a strategy that New Zealand took, and Korea, which is we are going to search out every case and get rid of it so that there's no disease circulating in our country. At least to this point, they look like they've done well. Second strategy is, well, if most of the people, it's more than 90% of the people recover, it's 95% at least of the people who recover. Kids rarely get it. Why don't we just sort of go back to things and let this happen? Well, the concern is that a lot of people would get it. I mean, this is a contagious enough disease that we know that in a population where you just let this spread and you don't do anything to do with it, about 80% of the population would get it. And we know that, so let's say in Douglas County, we have 80,000 cases, which would be a lot. Of those 80,000 cases, about 20% of those, so about 16,000 cases, would require hospitalization. That's a lot of hospitalizations. That's about as many hospitalizations as we have for everything else. So it really would put a strain on the hospitals. And of the people who have it, I don't know what the mortality rate would be, but it would likely be something like 3 to 5%. 3,000 or 4,000 deaths. So 3,000 or 4,000 deaths is a lot of deaths. I mean, we typically only have about 1,000 deaths a year in the entire county. So this would be a high death rate of 4 or 5 times the normal death rate. And you could deal with that. Now you say, well, no, we're not going to do that because we're going to protect seniors. Nobody has figured out how to let this blow through the population and protect seniors. Because, for the most part, seniors interact with people who are not seniors. So in nursing homes, you'd have to figure out some way that the people who are taking care of them wouldn't get the disease. We don't know how to do that. For people who are living in multi-generational families, and there are many of those, we'd figure out how to break up those intergenerational families. I don't think there's a way to do that. And then for caregivers, there are people who are there are many of us in our 40s, 50s, and 60s who are caring for their parents who are in their 70s, 80s, or 90s. And so it would be really hard to just protect the seniors and let this go with everyone else. England suggested they would try that for a while. It didn't work out very well for them. Sweden sort of suggested it didn't work out well for them. So if somebody could come up with a strategy to do that, that would be okay, but nobody has figured out a strategy on how to isolate our seniors. And it would have to go on for a long time, right? So it would have to go on for at least 2 years. So for my mom, you'd have to say, well, Mom, for 2 years, we're going to leave this stuff on the porch and not do anything else and not go to the doctor, not go to church. And for her, this would be really hard. So that's a possible strategy. And there are a couple of people who have gamed that out. So they've gamed out all the different strategies, right? So you have the New Zealand strategy, which is we're going to not let, it's an island nation, so relatively easy to do. So we're not going to let people in. New people are going to get quarantined. And we're going to really track down all the cases and going to see how that goes. That's sort of what Hawaii did. And Hawaii has a very low number of cases, and they've done it. Kind of what Montana has done and kind of what Alaska has done, and they've all done okay. There are other places then who've really opened up early. So, for example, Sweden has tried to do that. Other places have tried to do that in the States. And so far, it doesn't look great. Now, who knows? Maybe we'll look back 3 years and we'll say, Sweden was right. They just sort of ripped off the Band-Aid. They let this run through their community, and they're better now. And Norway, which has had more strict lockdowns and whatever, they're in a world of hurt because they've had lockdown for too long. So we'll see. I don't know. I really do not know how it's going to come out. I think at least at this part of the game, I'd much rather be New Zealand than Sweden. So Debbie says, I had all the symptoms in February. My Quest antibody test came back negative and was told to do the other test available. What is that test? So the other test is an antibody test that is done by a different laboratory. So Quest does one, LabCorp does one, Mayo Clinic does one, and the big laboratories are there. So the FDA suggested that if you have an antibody test that you don't believe, repeat it until you do. So I would just go to LabCorp or to Mayo Clinic or one of those other areas and get another antibody test. I think if you had 2 antibody tests that were negative, it's pretty likely that you had something else. And so the big question is, okay, what the hell did I have? Because, I was sick and I was coughing and I really had all these symptoms. What did I have? And we do know there's some data coming out that the other coronaviruses were fairly active in January, February this year. Metapneumovirus was also quite active this year. So metapneumovirus, another virus. And these viruses are enough to make you sick. They rarely kill you. And so there were almost no people in the U.S. who had COVID-like symptoms, negative COVID tests, and died, or even got hospitalized. So most of the people who felt crummy with this, but were never sick enough to be hospitalized, never sick enough to die, and never sick enough to have a low oxygen level. So the low oxygen levels with this COVID are really one of the most stunning clinical things. Where people have oxygen levels in the 50s or 60s that you just can't believe they're that low. And again, you would rarely get that with metapneumovirus or the other coronaviruses or influenza. So I'd get another antibody test and see which it is. And when the Seattle flu study is finished, it'll tell us all the viruses that people had flu-like illnesses in Seattle in January, February, and March had. What they're going to show is that many of them had influenza. They're going to show that many of them had COVID and that some of them had these other things, but it'll let us know which ones they had. Well, a couple of other things that we're working on now. One is that a study came out today saying, okay, what are the weird symptoms that you can get with COVID? And so they looked at a huge series of people with COVID in New York, and they found that there are a couple of things that account for just a very small number of people, but are really peculiar. So one is this anosmia, loss of sense of smell, which does not happen in very many people. But when it occurs, is quite predictive for COVID because there aren't very many other things that causes. The second is these COVID eyes, which we've talked about a bunch over the last 2 months. So these people have these kind of really red, they just look like they've been crying their eyes out kind of eyes. That again in just a few percent, but it's kind of unusual because it's not seen in other things. And the other one is COVID toes, which look like your toes get frostbitten. Again, not common in other things. Seem to be not that common with COVID, but when you see it is really a sign. So if you lose your sense of smell, you have these red COVID eyes, or you have the COVID toes, you probably should get tested. So Laura says, is it normal to get antibody test results back in less than 24 hours? Well, it does not take very long to do the tests. So the antibody tests typically take about 2 or 3 hours on the bench. What they do is they take your blood, and the best ones are the ones that they actually draw blood from rather than just doing a finger stick, and they look at the serum. Then they put the serum in the analyzer. It takes a few hours to go ahead and cook through. So you certainly could get them back in less than 24 hours. And so none of these tests take that long. So the PCR tests that we're talking about only take about 4 hours at the longest. The problem is that they have to be done in these big sophisticated labs, so they have to get to the big sophisticated labs. They then have to wait their turn to be next on these big sophisticated machines, and then the results have to come back. So that if you really want to get the results quickly, you could get the results on any of these tests within 4 hours. It's just that the lower priority tests, which are most of these asymptomatics, wait until the higher priority tests get done first. And so, yeah, you could certainly get antibody test results back in less than 24 hours. And again, the recommendation now is to go with one of the bigger labs. And again, Roche has got a great test. LabCorp, Quest, and Mayo Clinic all have excellent tests for antibodies. What we find out on some of these antibody tests, and you'll remember that early on there were hundreds of different antibody tests, and most of them got pulled off the market because they had relatively bad results. So some of those had 20% false positives, meaning you took serum from 2018, should never have antibodies against COVID, and up to 20% of the time they had antibodies, they came back with a positive test. Well, that couldn't be right. And so that in those cases, if a few percent of the population had the disease, but 20% of the time it came back positive, you couldn't tell what the answer really was. I think now the tests that are still remaining on the market, the Quest, the LabCorp, the Mayo Clinic, the Roche test, are all very good, and I think you can trust those if you get them. All right, one more thing coming on here. When we talk about the shortages that we're still seeing. So I know we talked a lot about PPE early on, and the thought is, well, those shortages of PPE should now be corrected. I only wish. So the story on PPE, and we're talking mostly about the high quality N95 masks and the gowns. So typically, 20 years ago, almost all the stuff was made in the US, and much of it was reusable. So the gowns were, for the most part, washed and reused. The masks were not reused, but these were typically an American-made industry. What happened over the last 10 years is this went from about 90% American-made to about 95% foreign-made. In January of this year, China and other countries recognized that there was a problem, and they diverted most of their manufacture to local. And for whatever reason, the U.S. exported a tremendous amount of our own PPE that we made in this country to other countries. And then in addition, there was a recall of gowns. So come the end of February, we were in a dire straits for PPE because most of the stuff that was US made was exported, and much of the stuff that we needed was single-use disposable stuff that came from overseas. So March, April, and May, most places had to beg, borrow, and steal to go ahead and get the things that they needed. There were a bunch of masks that were bought overseas that turned out to be fraudulent and not used. So most hospitals and whatever now are doing okay for now. But if we were to have a big increase in cases, if we were to have something else happen, they would again fall short of PPE. So as much as the PPE situation has quieted down a little bit, we are certainly not past that. We won't be past that until every place has built up their stores to where they need to be, and we're not close to that. So Jackie says, I have an endoscopy scheduled. Will I have to have a COVID test beforehand? So hospitals and surgery centers make up their own rules for having a test. We usually recommend that people do that because there are some studies that suggest if you're going to have a major surgery, you don't want to have a major surgery while you're brewing COVID. So unfortunately, what they found early on in China and in Italy were there people who were scheduled to have their gallbladder out or a hysterectomy or something, and it turned out they were brewing COVID at the time, and they did much worse. So I think it does make sense to have a COVID test beforehand, major surgery. Endoscopy, it's really usually up to the place to decide. So Patty says, my mother hasn't left the house in 3 months and she really wants to go shopping. She's 79, she has health issues. Do you think she's safe? So again, on the risk continuum, she's been in the house for 3 months, so she's presumably, if she even had COVID at any one time, she's done with it. So she's relatively safe. Shopping at a good distance, people wearing masks, maintaining social distancing, is a low-risk activity. So when you look at cases, there are very few cases where somebody gets this if they're wearing a mask and doing social distancing in a store. So if she wants to go shopping, that would be great. Now, would I have her go to a store that's super crowded like it is on Black Friday? No. Would I have her, wait in line with 1,000 other sick people? No. But if you get to the store, if you were to do your social distancing, if people were to wear masks, that's on the low, moderate risk continuum. And again, I hate shopping, so I would never go shopping, even if it was zero risk. But other people love to do it, and so they should do it. So people are making these little risk calculations for themselves as to what they want to do. So I talked to my mom over the weekend, and she just desperately wants to get her hair done. I've never seen her without perfect hair. So she said she would be embarrassed to go out. So it's all different for different people about what they want to do. And I think people don't need to fret about the one little exposure, like I really want to go shopping, and you take your mom shopping and you socially distance and you stay good and you wear masks and whatever. You don't have to totally fret about that. But then when I see these big crowds at the bar coming out of the bars on the weekends, that does worry me. Okay, we have one more question. We have somebody's got an appointment at 7 o'clock, so we'll try and be done in just a few minutes. Again, Douglas County is doing great. One of the questions that came up today was about contact sports. And it's a little confusing because the state guidance suggests no contact sports, yet we're hoping the Ducks and the Beavers get back into this. And again, I think you'll start to see the guidance change over the time. Right now for sports, it's perfectly okay to do sports where you're distance, but we're not doing contact sports. We're not sure exactly what's going to happen at the collegiate level. So the question is, why are positives and presumptives put together? Oh, because you have to do something, right? So if you have somebody who is positive, that means they have symptoms and have a positive test, they're clearly positive. Presumptive people are people who have symptoms and have had contact, but they don't yet have a positive test. And that's probably reasonable because we know that these tests are not that sensitive, meaning that up to a third of the people who have the disease will not have a positive test. And so you'd either have to consider that a negative test, a negative case, or a positive case, far more likely to be positive. So, what's the chance that if my wife had COVID and I had symptoms of COVID that I'd have something different? It could happen, but it's far more likely it's COVID. And that's kind of what we do with every other disease. So if you live in a family with salmonella, for whatever reason, they can't get my salmonella test, and everybody else in the family has salmonella and have bloody diarrhea, they sort of figure to have salmonella. So it's sort of what we do with every other test. And it is probably the most reasonable way to do it. To consider that not a case, I think, would be unrealistic, especially given the fact that our tests are not that sensitive. So in most places, when you have something that looks like COVID and you're hospitalized with COVID, they do a test every day. And sure enough, on the second, third, or fourth day of testing, they find a positive test. And since false positives are incredibly rare, these are likely to be true positives that just didn't show up on those first few days. So this is a complicated thing. It turns out that epidemiology is super complicated. So when we have our epidemiologists here, you've got these positive, presumptive, suspect cases, you have to consider all these things. It's really quite complicated, but I think Oregon is doing it the right way. Now, there is this group of epidemiologists throughout the country that work together, and Oregon has typically followed their guidance. There's always a tendency to cook the numbers one way or another to make it look too much or too little, too many deaths, not enough deaths, and there's always that risk in doing that. But I think that group, which is the state and territorial epidemiologists, has really done a good job of trying to avoid the political stuff and to try and do this in the best way possible. And that's why we put positive and presumptive cases together. Now, it turns out that most of the presumptive cases do become positive. So sometime later they get tested, and then they go from the presumptive to the positive. So you look at the number of presumptive cases in the state. That number while it increases, doesn't increase nearly as fast as the positive cases, because many of those presumptive cases will be positive. Okay, well, that's what we got for today. Again, this is Dr. Bob Dannenhoffer with another Facebook Live. We'll see you again on Friday. A couple of things. We do have our hotline still open, 541-464-6550. And we're still doing testing on Tuesdays and Fridays. So if you want to get a test, talk to your doctor or look on our website. And there's a number you can call at Aviva if you don't have a primary care doctor, and we'll do it. Again, the number of people with symptoms needing tests is way down. So in the beginning, there were 30 or 40 every time we did it. Now it's only 5 or 10 that need it for symptoms. We're doing a bunch for asymptomatic people who are going in for surgery. People just want it. People need them before travel or whatever. And so that number is going up. The number of sick people is going down, which is really great. Now, once we start spreading more, once we start going to bars and restaurants and whatever, we are going to get people with other symptoms, colds maybe, or flus even, that we do want to go ahead and test them for. So we'll have to see what happens. But right now in Douglas County, we're doing great. And thank you all for being so kind and so adherent to what we ask you to do. Thanks.